without much ado, I'll go to the topic in proper, that is botulinum toxin, the chemistry behind. So this is how we'll be going. So we'll be looking at the toxin and the chemical profile and what are the subtypes that's available for use and what are the indications, contraindications, and I'll show you some results from our own clinic. So this is what we are expecting. So Dr. Christian Kerner was the first person who initially linked the consumption of improperly preserved sausages to botulism. So this was published in 1870. And he named this the sausage poison because it paralyzed the skeletal muscles as the parasympathetics. And it was Dr. Alan Scott, who in 1980, who used it first initially for strabismus. Then Sree et al. Reported initial results of double-blind study of botulinum toxin as spasmodic torticollis, which was the first initial use. So initially it was basically used for cervical dystonia. So the toxin is produced by spore-forming anaerobic bacteria, Clostridium botulinum, and then there are a few other subspecies also which are important. And it's one of the most potent biological toxins. 1 gram can kill 1 million humans if used properly. So this is a structure. So you have a disulfide bond which links the heavy as well as the light chain. So you have the light chain here. This is the cleavage site. Cleavage site means this light chain is the one which is doing the job for us. And this heavy chain is the one which helps in translocating the toxin moiety and getting it bound to the receptor. And this is the receptor binding site, which is as carboxylin, and this is the amino terminal end. And if you look at it, there are a few other proteins which surround this toxin, which is called as a hemagglutinin protein. So what are the types that we have? Based on the serological typing, we have 8 types, A to H. And there is subtle difference in the serotypes, and subtypes differ structurally. So significant differences are also apparent in the toxopharmacological properties. And A and B are approved by US FDA for clinical use because of the prolonged mode of action. They have different affinity for motor and autonomic nervous function. B is mainly for the autonomic, whereas we are often using the A type. So these are the brands which are currently available in the market. So we have used all these first 4 except MyoBlock. So onabotulinum toxin was the first that we have used. This is by Allergan. And then came Dysport. So currently Dysport is not available in India. Xeomin is another one which is also called as incobotulinum toxin. This is one of the most purified forms. And there you have Zarbot, which is also a botulinum toxin type A. So if you look at the clinical efficacy, Zarbot, Botox, and Xeomin is almost like 1:1:1. Whereas for Dysport, it is almost like 2.5:5. So for each unit of Zarbot or Botox, you will have to use 2.5 to 5 units, 3 units of Dysport. Whereas for MyoBlock, it is 50 to 100. There are certain novel preparations of botulinum toxin type A which are currently available, but these have yet not been marketed in India. One is nanobotulinum toxin A. The other is daxi-botulinum toxin A. So daxi has been approved for cervical dystonia. The main advantage is that it can be used, the efficacy almost lasts for 6 months or 24 weeks or 6 months or more. But initially before you use daxi, it is advisable to use the one of the initial ones like either Zarbot or Botox, and be very careful regarding the muscles that you select. So once you are sure about the muscles that you have selected and you know the outcome is good, then you may go for the same preparation of daxi-botulinum, same units. Now coming to how this molecule works, this is a short.
In the normal nerve ending at the neuromuscular junction, there exists numerous small preformed vesicles containing the neurotransmitter acetylcholine. As an action potential travels down the nerve and reaches the nerve ending, it causes the acetylcholine-containing vesicles to dock to the terminal of the junction. The membrane of the acetylcholine-containing vesicle fuses and releases acetylcholine into the synaptic cleft. Acetylcholine is then bound to the postsynaptic muscle membrane, and muscular contraction is initiated. Allowing the preformed acetylcholine vesicles to dock and fuse to the membrane is a structure termed the synaptic fusion complex, which is made up of a group of proteins known as the snare proteins. Two sets of snare proteins exist and are required for fusion and neurotransmitter release. One on the acetylcholine-containing vesicle, termed synaptobrevin, also known as vesicle-associated membrane protein, or VAMP, and another group on the neuronal membrane called soluble N-ethylmalamide sensitive fusion attachment protein 25, or SNAP25, and syntaxin. The snare complex formation is an energy-releasing process that may supply the required free energy for membrane fusion. This snare core complex is the location for the mechanism of action for botulinum toxins. If one or more of the snare proteins are damaged, the acetylcholine-containing vesicles cannot dock and fuse, and acetylcholine cannot be released. Botulinum toxin type B consists of both a heavy chain that binds to synaptotagmin and a light chain which is internalized into the vesicle through endocytosis. Within the vesicle, within the nerve ending, the light chain, through a yet-to-be-determined process, translocates the vesicular membrane and through an enzymatic process cleaves synaptobrevin in the acetylcholine-containing vesicles in the nerve ending. This process results in an inability for the acetylcholine-containing vesicles to fuse, and as a result, chemodenervation occurs. Once synaptic transmission is inhibited, the target structure no longer functions. In the case of skeletal muscle, it means muscle contraction ceases. In response to this chemodenervation, which results in inhibition of acetylcholine release, new, smaller, unmyelinated nerve endings, termed peripheral sprouts, are formed which are able to restore normal neurotransmission. Thereafter, the light chains are degraded within the nerve terminal that was originally affected by botulinum toxin. Normal neurotransmission can be reestablished and the nerve endings that sprouted retract. Peripheral sprouting usually begins to occur in 28 days, and normal nerve transmission is normally reestablished in approximately 3 months following botulinum toxin injection.
So this is a schematic diagram. So this is the heavy and the light chain of the botulinum toxin. The heavy chain binds to the receptor, surface receptor, and the synaptic vesicle 2, as well as synaptophysin, which is there on the surface of the vesicle, helps in taking this toxin within the vesicle. So once the toxin in botulinum toxin is there within the vesicle, an acidic medium is created by this cation pump, and then the acetylcholine is also there within the same vesicle. So by a still yet unknown process, this is extruded out. The toxin is actually extruded out, and the catalytic enzymes work on this, and the light chain is cleaved off. Once the light chain is cleaved off, it can work on 2 targets, that is the VAM, vesicle-associated membrane protein, or synaptobrevin. So botulinum toxin type B works on VAM, whereas botulinum toxin type A works on SNAP25. SNAP25 stands for soluble N-ethylmalamide sensitive factor activating protein receptor. So VAM, SNAP25, and along with syntaxin form the snare complex. So botulinum toxin type A works on degrading the SNAP25, whereas botulinum toxin type B works on the VAM. So either way, the docking of the vesicle to the membrane is prevented. So that is the mechanism of action. So the docking is prevented, and no more release of acetylcholine can happen. So it's a presynaptic blockage which is happening. So this is the nutshell of how this molecule is going to function. Now, are there any other mechanism? It also prevents release of other neurotransmitters like substance P and CGRP and ATP also. So this is very important when it comes to pain modulation. So this is one way it works in chronic headache. It also negatively regulates the sensory receptors involved in pain pathways. Example is transient receptor potential cation channel 1, that's the TRPV1, also known as the capsaicin receptor. And it also works on the vanillate receptor 1. These are all basically pain receptors, and also on the purinergic receptor. So negative regulation of these will also reduce your pain threshold. And hence this is very important in managing autonomic functions where it works in reducing the hyperhidrosis as well as in pain syndromes. Now, can there be non-responsiveness to botulinum neurotoxin? Yes, that can also happen if you develop neutralizing antibodies which can jeopardize the sustained response to the toxin. Now, what are the determinants which increase the risk? One of the most important determinants is the narrow interval between the injections and giving booster doses soon after the first dose. I can explain that. Suppose if you have injected a person and he comes back to you within 4 weeks or 6 weeks saying that he hasn't had the desired benefit, and then you try to address that by giving another injection, and if you keep doing that, he is at high risk for developing neutralizing antibodies. So please don't do that. Give at least a 3-month gap between each interval of injection. So that will reduce your risk of developing these neutralizing antibodies. So the other point is that if there is a protein moiety, so certain toxic formulations will have a protein moiety, and this protein moiety will predispose you to develop a neutralizing antibody. So very pure proteins like ingobotulinum is one of the purest form which is available. That has the least risk of developing neutralizing antibodies. And higher individual and cumulative toxin dose also increases your risk. So percentage risk for developing neutralizing antibodies is virtually 0 for Ingo, whereas it's maximum for RIMA, that is approximately 42%. So what are the guiding principles? Always try to get a videography of the patient at the baseline and keep a record of which are the muscles that you are targeting, what is the dose that you are giving. This is very important because those who are giving cervical dystonia will know that after some point it is very difficult to identify which are the muscles, and you will have to go back to the record to identify. So at the first instance, videograph the patient, carefully select the muscles, look and carefully note each unit that you are giving for each muscle. So based on which you can either titrate, increase or decrease when the person comes next time. And document each response and adverse effects in that same sheet. And maintain a minimum of at least 3 months between 2 injections. Now what are the indications? So all these are indications: hemifacial spasm, blepharo, cervical dystonia, writer's cramp, all dyskinesias, lingual dystonias, spastic armtocomia, and chronic headaches. And if you look at the evidence, there's perhaps level A evidence only for cervical dystonia, whereas you have B and C levels of evidence, but that's not much of a concern because we know it works. What are the contraindications? There is only one absolute contraindication, that is neuromuscular junction disorder. So that is something which you need to be careful about. And the other 2 are pregnancy, lactation, we'll say less of significance. And if you have a local skin infection or something, so take care of that before you inject. And adverse reaction, if there is anything, you may give a time interval and go for an alternate preparation thereof. And if you have developed fixed contracture, there is no effect even giving a last dose. You have to be very careful. It would have gone into a fixed contracture. That means fibrosis would have set in. There is no more muscle tissue to be targeted. So that is another thing which you need to keep in mind. What are the must-haves in the lab? This is one book we always keep in our lab. That is the Kalda Mistra for identifying the muscles. And these are the preparations which are available. Dysport is currently no more available. So we virtually function with Zarbot and Botox currently. So how to reconstitute? Always use 0.9% normosaline. So these are the diluents. So for face and all, we usually use 2 ml. And for larger muscles, we give 4 ml dilution. So it's up to you what you do in your lab. So this is the EMG guided needles that we use. So we have two gauges. That is one which is longer for the deeper tissue. The one is a little more shorter one. So this is the EMG needle. So this is a good technique to have an EMG guidance when you are injecting. And for skin and also for facial muscles, we use the insulin needle, which is very used, and we apply Prilox approximately 15 to 20 minutes prior to injecting. So that virtually eliminates the pain of injecting in face, as well as for chronic daily headache syndromes, we use this technique. Now coming to certain videos, I'll just show you. So this is a patient with
So
the most important thing is to avoid falls. Don't be overdosed more. So that will cause a lot of problems. So just be minimally when you keep an insulation program angle. So this is another case. He had ocular tics.
199 തിരിച്ചെണിക്ക്
So in these cases, sometimes they can avoid the dorsal plate. Dorsal plate is open under the solidarity before spasm. Otherwise, you can avoid the dorsal plate. So this is a case of lingual dyskinesia.
വീട്ടിന്റെ അഡ്രസ് പറയും. തിരുവനന്തപുരം മെഡിക്കൽ കോളേജ് എന്ന് പറഞ്ഞു. 100 കുറച്ച് എത്ര ആന്ന് കാണിച്ചേ. മെഡിക്കൽ കോളേജ് പത്മനാഭസ്വാമി ക്ഷേത്രം. പത്മനാഭസ്വാമി ക്ഷേത്രം ആന്ന് തുറന്നേ. നാക്ക് വെറുതെ അകത്ത് വെച്ചാൽ മതി. ആ കാണിച്ചു.
So this is another patient who had a very bad upper limb dystonia. You can see that the entire limb has gone into internal rotation, severe internal rotation, extended posture, very significant severe flexion of the wrist, fingers and metatarsophalangeal joints. And this is the same patient post-Botox. So you can see how the muscle is. So this is one patient with hemimasticatory spasm. So you can see this continuous activity of the masseter which is happening here. So post-Botox, the spasm has entirely disappeared. So after repeated injection, you may develop a little bit of masseter atrophy. So these are children with spasticity. So you can see this side. Ambulate only with support. So this is the same patient. Post. This is another child. And this is ambulation. This is after the first course of botulinum toxin. So this is the kind of improvement you can develop with this one. This is very gratifying and very satisfying. So thank you for the patient listening.